And I'll say as a caveat, normally I'm in these settings talking about the science of inflammatory bowel disease. You guys had a very excellent session on that already. And not as much of an opportunity to talk about things like ABIM and some of the adult learning theory, andragogical principles of this and some shortcomings. So I appreciate the opportunity. This is the first time I think in 20 years I'm not giving a talk that has a p-value associated with it, which may be a good thing for a lot of you in the audience. And I think the reason that I'm here is, as Dr. July mentioned, I serve as the chair of the ABIM Gastroenterology Exam Approval Committee. So this is the group of us that do the initial and 10-year MOC exams. I'm on that committee with Lynn Chang, who many of you know, which is I think why I was offered the invitation, for which I'm very appreciative. So maybe the first thing I can just say, when I mentioned myself and Lynn and others, largely from academic institutions, but we also have a few private practitioners, is to maybe start by dispelling the myth of this us versus them. I can tell you, until a few years ago when I was on the ABIM committee, I had maybe a sense of that as well. But those of us that are on the committee are largely people who have roles in our major societies, including on education and training committees. And we're all kind of in it for the same reason. And for those of us on the committee that aren't full-time ABIM employees, that are members of academic faculty throughout the country, it's important that we work together on the shortcomings that exist. I know that I've definitely been a thorn to some degree on the ABIM side, talking about some of the ways that we need to come together in a more effective way. And so I think it's important that we appreciate that we work on this collaboratively on ways to improve over time, because honestly, medicine is well behind areas like pediatrics, anesthesia, and others in how we appropriately make sure people stay up to date. So this is a quick poll out of curiosity, and this, I know there's probably some APPs in the audience and others are practicing physicians. If you can raise your hand if you were certified in GI before 1990. So an okay number. And then, so for those of you, this will have varying degrees of relevance, whether you were certified before or after 1990. And so we'll talk about some of the current data for the ABIM board certification, and mostly focusing on recertification, unless there are some senior fellows in the room. Explain the new menu of options to maintain certification, and discuss some plans that we have to revise the blueprint that has kind of been a grassroots effort from those of us on the committee that have gone to the ABIM asking for some updates and improvements in the blueprint. And maybe my hidden objective is, for those of you that are on faculty, one of the banes of my existence in fellow conference is when someone says, and this will be a really good question for the boards, even though they've never actually sat on a committee that writes board exams. And so that largely comes from this era when board exams were about, let me think if I can find the most esoteric question available. And I hope to convince you, particularly if you've taken the exam in the last few years, that that is not meaningful for learning, and certainly not the way that the ABIM plans to move on this going forward. So just a little bit of background about the ABIM. It was started about 90 years ago to try to create uniform standards within internal medicine. It now certifies about a quarter of all of US physicians, just because of medicine and its subspecialties being such a large part of the practice of medicine in this country. It's one of about 24 members of the ABMS, which is the larger umbrella organization of medical specialties. It's physician-led. Those of us that are doing basically volunteer work for the ABIM aren't part of their employees, but a lot of the leadership structure are physicians at the ABIM. And I'll really emphasize here that the point of the ABIM is it's focused on evaluation, not content delivery. And so the expectation from the ABIM is that you get content delivered from other places. That could be the AGA, the ACG, conferences like this. And it's really focused on evaluation. One of the challenges in that, for those of you that may live, I'm an associate in education at the University of Miami, so I live a lot of my non-GI time in the education space, is that meaningful evaluation for those of us in this room would be how well you actually perform colonoscopy. How well you, and if you can't get that by a rail proctor, which may have obvious limitations, maybe simulation. How often are we talking about doing simulation to see if we're still doing a good job? Even if you don't do that, how about seeing what my actual adenoma detection rate is, like you heard from the last session? That to me is more important than whether you can answer a multiple choice question about when to surveil somebody, is whether you're doing a good job doing the actual work. And if not that level, what about something that's more open-ended? Wouldn't it be better if we could evaluate somebody, asking them a question, having to hear through their thinking process rather than just taking an MCQ or multiple choice question? The reality, however, is that MCQs are by far the easiest thing to do, and that's why whether it's the USMLE exams or the ABIM exams or others, they have this. I'll note that organizations like surgery and OBGYN continue to this day to have oral examinations as part of their process. Medicine got rid of it long ago. That's for ease, but you do, in exchange for that, lose some of the context of being able to meaningfully evaluate whether someone's a good doctor, not just whether someone can answer a lot of multiple choice questions. And the ABIM constitutes internal medicine and about 20 specialties. Largely, those overlap with the ACGME residencies and fellowships. For us, that includes GI and transplant hepatology. Importantly, those of you that may have been part of academic institutions or did fellowships in IBD or advanced endoscopy or motility, these are not ABIM boarded. I run an IBD fellowship, and I'm very thankful it's not, because we have a lot more flexibility when you're not part of the ACGME. Transplant decided about 15 years ago to go down that route, as did some specialties in cardiology. My personal opinion is that that's better governed, if you will, by societies and not by the ACGME. But you can see that we're part of this for GI and for transplant hepatology. And just to give you a rough sense of the numbers, there are a few 100,000 general medicine certificates given out for those that are just in internal medicine. We have about 17,000 folks that are currently certified in gastroenterology throughout the country, and I put transplant there as a much smaller number, but since some of you might be transplant hepatologists. And this is one of the bigger groups. Cardiology has about double this, 35,000, and then pulmonary critical care and oncology are about the same size as us, but we are one of the biggest specialties in terms of number of people with valid certificates. And when you look at certificates, they come in kind of two forms. And so I put at the top here the first-time pass rates, the pass rates for first-time test takers. And what you can see across the past few years, and there is a little bit, we'll see what the pandemic effect was over time, but certainly you see a general ballpark of upper 90s pass rate for first-time test takers. So a very high pass rate. This is not intended to be something that weeds people out unless they really aren't meeting baseline metrics. And the maintenance certification is a few percentage points lower, but still in the 90s. And I'll note that the maintenance of certification removes a lot of things that have been perceived to be not relevant for the practicing clinician. So some of the things that might be on a first-time exam and not on MOC would be maybe a really pathophysiology-based question. If you're interpreting something about achalasia, knowing the difference between type 1 and type 2 on the actual manometry versus just saying in the question the person has type 1 versus type 2, what's your next plan? In first-time test takers, you might actually have to look at that high-resolution manometry, and maintenance, you would just get the fact that it's type 1 or type 2. I would argue that's not the right way to go. I'm not sure why someone who's 10 years out versus 1 day out should be any more or less qualified to answer a physiology question or interpret a manometry, but nonetheless, that's how it is. And despite those changes, there's a slightly lower maintenance certification rate, but still we're looking at the 90s, so a very good rate. So obviously this isn't a perfect situation. So about 8 years ago, multiple societies that you see on the top there, basically all the major GI societies came together and advocated for change to the maintenance certification. And they came up with these 5 major points about how they wanted things to change. And so they wanted to be simpler. I find there to be very unlikely to be any argument about wanting to have a simpler process. An alternative to a 10-year exam, also hard to argue that that's not an important component. And as I mentioned, there are several specialties across the ABMS now that have no written exam at all for maintenance and just use whether it's journal clubs or online questions. Groups like pediatrics and anesthesia have led the way on this, and so again, hard to argue that. They also mentioned open book, given the reality that current clinical practice is that nobody in this room or collectively in this room is smarter than the phones in our pockets. And so if the reality of modern medicine is to use data that's available to you in your smartphone or your online tools, then why not use that here? And so this has been implemented, and for the past 5 years or so, on the maintenance exam, you can use UpToDate. So there's a proprietary relationship that you can click on an UpToDate link, and then you can go to UpToDate to answer some of your questions, because at the end of the day, if that's what you're doing in practice, that should reflect what you're doing on the exam. That is not being used on the first-time exam, and again, I would argue, I'm not sure why it matters, right? I mean, if you're 1 day out versus 10 years out or 20 years out, should you not be expected to be performing the same level of care and quality of care for your patients? But nonetheless, open book has now been a part of this. The next point I would argue is aspirationally great, that we should be in lifelong learning, not lifelong testing, and so should we get rid of tests? Well, that would be great if people responded only to carrots and not to sticks, but I'm sure all of you are here for very altruistic reasons of wanting to be better for your patients, but you're probably also here to some degree because it provides CME, and in this case, actually MOC points as well. I will tell you that as a personal opinion, I think that in medicine, we've become very defensive about our knowledge and our need to retest. If you look at the example, for example, in aviation, which to me is the gold standard of really expecting their people to be held to a high standard. For those of you that have either, obviously everyone knows the story about Sullenberger, who landed the plane on the Hudson, and then maybe you know him better as Tom Hanks, who played him in that movie. But if you might know the story that for the next 6 months after that, he was not working on across all the talk shows across the country talking about what an amazing job he did and all that. And so several months later, he had to get back into the cockpit and start flying again. And he had mentioned on one of the morning talk shows that before doing so, he had to get 100 hours of simulation training in before they would let him get back in the cockpit. And the host had said, "I don't understand. You are arguably one of the best pilots in the world. Why do you have to go back and do what people who are just out of training have to do?" And interestingly, rather than being defensive, he was actually kind of confused by the question. And he said, "How can I not be? Shouldn't we all expect ourselves to be held to that standard?" And I would say to you that if someone graduated from fellowship in 1987 and is still doing colonoscopies today, I am sure that most of them are excellent at what they do. But when have we ever actually checked on that? And when have we actually held them to a standard? And when have we as a community expected ourselves to be held to that standard? I should be perfectly comfortable having somebody audit my colonoscopy or my endoscopy or my charts, and we should be doing this. So I think this is a great aspirational view to say we shouldn't be involved in lifelong testing, but the reality is until we live in a world where people are consistently holding themselves to lifelong learning, this is unfortunately a part of the reality. The final piece that was important in maintenance was a request to have customized assessments based on practice profile. So I'll give you an example that my practice is 100% inflammatory bowel disease, and I trained in an era before DAAs were available for hepatitis C. So in my personal practice, I don't know that I've ever actually given a prescription. The last time I did was probably as a fellow giving pegylated interferon and ribavirin. So I don't treat hepatitis C, or I rarely, if ever, will screen somebody or surveil someone for Barrett's esophagus. And so should my assessment be more heavily focused on what I do and less on the others? And so that's the argument in favor of this. The flip argument is that this certification isn't in IBD or Barrett's or hepatitis C. It's in gastroenterology, hepatology, and nutrition, which is like the kind of overarching field. And if that's the case, why should I still be certified in gastroenterology as an overall practice if I can't answer the appropriate question about how to deal with a certain type of patient with hepatitis C and what the best regimen for that person is? Now, I'm removing from this the reality of insurance and credentialing and all that, but from a purely kind of academic perspective, the argument against number 5 is if you're not able to keep up with the breadth of our field, then maybe the societies should determine that you are a specialist in IBD or Barrett's or hepatology or whatever field it is, but maybe you shouldn't still be board certified in gastroenterology if you can't do those things that meet the baseline metric. Because at the end of the day, if I tomorrow then go out into practice in rural Montana, I'm gonna have to practice general all of gastroenterology. And if I'm being certified because I took a test that was heavily IBD, and I'm being sold to patients as someone who's good in general GI, that may or may not be fair. So these are the kind of competing ideas that go into whether or not it's not so easy to just say we're going to change everything about MOC. So I'll pivot for the last several minutes just to give you some examples of what's happening currently in maintenance with some changes that are going on. And so I just pulled as a screenshot from several weeks ago my ABIM certification. So there's 3 parts of this, and all of you can go onto the ABIM website to see this. And so on the bottom on the right, you can see that when someone was initially, I guess this shows my age now, whether that means I'm young or old, I don't know, but you can see when I was initially certified for the 2 specialties in internal medicine and gastroenterology. Then a couple lines above that is your current status, whether you're currently certified in your current one, which for us is GI, and whether or not you're still in medicine. I thought I was one of the very few people still like actually certifying in medicine, but then while Samir was talking, I looked him up and he's actually still certified in internal medicine too. So good for you. And now you are not required to still be certified in medicine. Once you pass the initial, all you have to do is do your most current one, so you can stay in GI and lose medicine. And then the third part is whether you're participating in maintenance certification. And so the reason this part is important is even if you're still certified, if you're not doing both of the parts on the left, points and assessment, then you'll not be saying, it won't be saying yes under participating in maintenance certification. So maintenance is both the assessments and the points. The caveat that I asked about who trained and certified before 1990 is because if you were certified before 1990 in any ABIM specialty, then you were grandfathered in. That's great for the people who in 1989 decided that was the cutoff. I'm not sure what's magical about a person who finished in 1990 versus 1991, that someone who graduated in 1989 somehow never needs to take a test again and knows all of GI forever, but someone who graduated in 91 needs to be held to that standard. So we'll leave the politics of that decision out, other than to say that obviously as we get a move on in time, fewer and fewer people that certified before 1990 will be in practice as they slowly move towards retirement age. So this will be less of an issue, but it is an interesting intellectual point about why the magical 1990 year. But what you see is the assessments. You'll see that you have to take either a test every 10 years or LKA, which we'll get into every 5 years or over 5 years. But importantly, MOC is also about points. And so you have to accumulate 100 points every 5 years, and you have to do something at least every 2 years. So it's some kind of quality, continuous quality improvement. I put the website of examples of activities where you can get CME that also provide MOC. 2 quick examples. This conference today is not only CME, but also MOC, which is a great opportunity for you to get some MOC points. I run our grand rounds for Department of Medicine at my institution, and so we put forth the application. So now when our faculty are coming to our grand rounds, and we have about 35 or 40 medicine grand rounds a year, they can not only get CME, but also answering a couple of questions, get MOC as well. So there's easy ways at your institutions or groups to add some of this. And this is mostly medical knowledge, but there's also opportunities for those of you that are involved in academics. If you're a program director or you're involved in GME activities or patient safety and quality improvement, there's also ways you can get points based on those, but they're mostly medical knowledge. And so the points option, there's a lot of different ways you can do these online ABIM annual updates. There's you can, if you guys use UpToDate, you can get MOC points for that, and you can do other things you see on this slide. In terms of society meetings, many of our national meetings, including things like ACG, for DDW, just the postgrad courses count as MOC. They don't have it for all of DDW. And then, of course, regional courses like these are also an opportunity to get both CME and MOC, and again, 100 over that time course. So historically, this was just a 10-year exam. In 2018, they experimented. You can see that there's an end date of 2021, so that was a 3-year experiment in something called the Knowledge Check-In. Some of you may have done that. It was an option to do this at home with a 2-year cycle, and this is a graph or comparing Knowledge Check-In from traditional MOC exam on the right. It's less relevant in this era because we've basically, as of last year, transitioned out to LKA, which I'll spend the last couple of minutes talking about, which has been available for GI since last year, not yet for transplant. It's unclear whether transplant has enough diplomats to warrant moving to an LKA exam, but certainly it is for GI starting this year. And I would say the other opportunity is in cardiology. The ABIM worked with the American College of Cardiology to create a collaborative pathway. This has not yet happened in our GI societies, but I think it's a nice opportunity to bring the societies and the ABIM together to do something that's collectively in the best interest of our practicing gastroenterologists. So the LKA is a 5-year cycle. You get a set of 30 questions every quarter. So if you calculate that out, that's 120 questions a year and 600 questions over the 5-year time frame. And you have to answer 500 of those 600 questions. So you can choose which 5 out of 6 on average questions to answer. You get 4 minutes per question. If you look at standardized tests like USMLE and ABIM, there's kind of a standard of 90 seconds per question. This is much more time because the idea is for you to think through it, use resources if you want, like you would in a regular clinical practice, and you can use anything except another person. This is on an honor code, and you get 4 minutes per question, and you do the questions at that 30 questions over 3 months, however often you want to do. If you want to dedicate a Saturday afternoon, hopefully you have better things to do on a Saturday afternoon, but if that's what you want to do, that's great. If you want to do 1 question a night every few nights, however you want to do it, the question at your own pace, and if you don't open it, then that expires and you go to the next 30 questions every quarter. And importantly, you get immediate feedback. So as you answer the question, you'll get the rationale and the references to identify these deficiencies and potentially address them, and feedback on how you're doing relative to the national passing standard. And then you'll get the number at the end of the 5 years. As you can imagine, this requires a lot of changes in how we make questions, because you have to make questions that are really delivered, that aren't just if you can look it up and get it in a second, it's not a meaningful question. So we need a much bigger question bank and different kinds of questions. And this already started changing with the addition of UpToDate 5 years ago, and a reorganization of our committees. So now our committees I mentioned earlier, are really looking over the questions and approving them with a much larger group of what they call item writer task force that are actually making the questions. And so some of the key features I mentioned already, things like you don't need to make an appointment, you get 4 minutes a question, immediate feedback, and I mentioned a lot of these issues already. You can use any resource except a person, and all of these things hold over the course of the entire 5 years, and you get your official longitudinal approval, and you're good until the next 5 years. And I mentioned these issues already about the benefits of the questions, the immediate feedback, and getting the results. And so if you're currently certified, then you can start participating immediately. If you're certified before 1990, you can use it for the participation requirement, but of course you're indefinitely certified. And if you're lapsed, you can use it to regain certification. You'll still be listed as not certified until you are, but you can use this as an opportunity to regain your certification. And you can switch between back and forth pathways, and every successful year that you do it, it pushes back your assessment a year if you choose to switch pathways. And so I'll close just by telling you that the ABIM as an organization does assessments, not content. But of course, if you're looking to study for a test, you need to know what kind of content will be delivered. And so what you see on the screen is the current way the blueprint is organized by organ system, basically on the left. And then there's a set of green, yellow, and reds about what you can expect on the test. And this is available on the ABIM website that I listed there. There's some obvious problems to this. So in cardiology, which is largely one organ, as you might imagine, their categories are not left ventricle, right atrium. Their categories are things in practice: CHF, arrhythmias, structural heart disease, valve disease, etc. That's not so easy in a field like GI or endocrine, where there's combinations of a lot of organs. And so endocrine, for example, has things like pituitary and thyroid, but then has things that are really content, like diabetes. And so it's important that we flex. There are some benefits to the organs, like you can put GERD and EOE in one field of esophagus, but where does not SIBO, but where does IBS go, or where does inflammatory bowel disease go? Does it go in small bowel, or does it go in colon? And so then we think about, when can we put them in categories like inflammatory disorders? But that doesn't work, because if you put inflammatory disorders or autoimmune disorders, then autoimmune, hepatitis, and IBD are in the same category, and those are clearly not going to help you study for the test. And so currently there's a revision in place, since organ-based doesn't represent our practice. And the big elephant in the room there is that there was no category for endoscopy or peri-procedural issues and anticoagulation or antibiotics, or how to deal with surveillance and all that. So, and so the ABIM and the major societies agreed on a need to reform. And so there's a practice profile. Some of you may have gotten this survey about what diplomats actually see and treat. And so we're currently working on restructuring this. And there was a preliminary message sent to some of the major societies that's going to be revised and sent out again this summer. That's hopefully going to kind of combine the idea of organs and disease processes with multiple levels of that, so you can very easily look at the content and decide how best to study for the exam. And so I'll close just by saying that the ABIM's website is actually a helpful resource. A lot of these graphics were from the ABIM website directly, and you can look at that for general requirements. And when you sign in, it'll give you very specific stuff about how you where you are in your pathway in terms of number of points and how close you are to needing your assessment again. So I'll stop there, and thank you very much for your time.
I'm going to take a couple questions.
Sure, of course.
Okay, all right. So floor is open for questions. If anybody has one, I'll just ask one while we're waiting. So the longitudinal assessment just went into effect last year. So if you're someone who was waiting to take the 10-year test and you now decide you want to go do this and you're 3 or 4 years behind, can you take all the questions now and get it in before the 5-year interval, or are you going to go ahead and do the one-time test?
Yeah, so I think if you're coming up soon, you can obviously decide which one you prefer. With the way the LKA is, it's rolling 30 questions every quarter, so you can't just like ask for all like a larger chunk at once. So if you're still up to date, I would suggest that you have until that time to start. And then once your certificate is close to lapsing, you can start. Remember, every year that you do the LKA pushes back that assessment due date a year. So depending on how far out you are, you can decide if you want to start the LKA a little early and then keep pushing that back a year. And then once you get to the 5 years, it's a full 5 years again.
Gotcha. All right, any other questions? One more?
Michael Marievsky. So I started doing that LKA testing. I think I've done 2 modules already, and it's going well. I actually like it. There's some feedback. The only thing I don't understand is how am I doing against the other people that taking it? When will I get that result?
Yeah, so it's a really important question. One of the goals is to really give you kind of regular feedback on how close you are to meeting that passing standard. The challenge when it's less than a year old is not having enough data to be able to know. Because the other issue is that if you know, obviously for those of you taking the 10-year exam, there's no feedback because it's a closed thing where if once the feedback is out, then people know the questions, you can't reuse the questions. So the LK requires a much bigger test bank where you know that you can basically only use the questions once or twice before it's no longer a valid question. And so the combination of the length of time that you need to have enough data to give you meaningful feedback, as well as creating a big enough test bank. That's the goal, is that right now you get preliminary feedback, but the goal is to really have that be much more mature, where you can see exactly on a kind of a continual basis how close you are. Are you falling below the curve, or are you doing okay?
So when will it happen? Like in a year or two, or like?
Yeah, well, those of us on the committee are pushing as hard. So there's also psychometricians that are employed by the ABIM that tell you when the validity of this and the indices of discrimination of each individual test question meets that. So I'm hopeful. We've been told that this is soon, in the next year or so, that we should be able to get meaningful feedback, that you not only get that kind of how you're doing right now, but actually like a graph. And so we're pushing them to do it, and they know it's a priority. They're just waiting to get enough data from the psychometricians.
And then, sorry, another question. After 5 years, assuming I'm doing good, like on an average, whatever the line is, if I pass, I don't have to do anything for 5 years or for 10 years? What is it?
You're good for the next 5 years, but then you're still going to get, unless you switch over into the 10-year assessment, then you're going to, the goal is it's kind of continuous, right? So when you finish that 5 years, you're good for the next 5 years, but you then start your next 5-year cycle where you get 30 questions a quarter.
There's no even a 5-year period, right?
Well, the 5-year period was the period that you were doing it. And the idea is that, the idea conceptually is that you're doing 30 questions a quarter indefinitely, rather than just having to take one test every 10 years.
So basically it never ends. It just goes on, right?
Well, it's in the same way that, yeah, it's in the same way that that's why some people might prefer to just say, I'm going to take a test and not worry about it for 10 years. That's the easier route to do. In terms of the kind of pedagogical or andragogical thing, it's much better to continuously be doing stuff. So other groups, by the way, other specialties have gotten rid of the 10-year test. It's not even an option anymore, and they only do this because they know the best way to maintain is to constantly be doing, now constantly, hopefully it's a reasonably low bar of doing 30 questions every 3 months or 10 questions a month. But yeah, that would be the idea.
So what would be the difference between somebody who passed a certain amount of questions well after 5 years and somebody who didn't? Because both groups will continue doing it, right?
Right, but if you don't meet the threshold at the end of the 5 years, then you're no longer certified, and you either have to take a 10-year exam or have a lapse certificate.
You can't do 5-year anymore if you just fall below.
You can, but you have to get to assessment passage first, and then you can continue.
All right, thank you.
Dr. Gupta, I think we've got time if you had a question.
My question is, I'm still, like, I started the LKA for internal medicine, and I can't tell, like, can I fail? Or is it just that as long as I do the questions, it checks the box, and then I'll be internal medicine certified?
So you do need to meet the passing threshold. So I'm not sure how the IM group is defining the pass, but it's probably going to be the same the way the GI does. And so you'll get a sense as you do more, and they have more metrics to give you whether you're at the passing threshold or not. It isn't 100% pass rate. So if you're doing 30 questions a quarter, you're getting 25 of them wrong, and if you're doing medicine, you're doing something about diabetes or something or hypertension, and you don't get enough of them right, then you will be below the passing threshold, and then you'd have to either take the 10-year exam or have a lapse certificate.
Okay. And then is there some ballpark target for GI or for medicine they have in mind, like 70% of the questions or 80%? I mean, the risk here is that, someone could spend a fair amount of time doing this without, I'm not studying for the 30 questions. I just take them and I try and learn as I do the questions. But it could be that I don't realize how far behind I am and that I really do need to, formally study. So I guess when I'm doing the questions every quarter, I have a sense I got 25 right, I got 28 right, whatever. But like, is it going to be about 70%? You're going to need to get about 70% of the questions right, 60%? What do you anticipate?
Yeah, my guess, again, I don't want to represent the ABIM in this at all because actually it's the psychometricians that will make this determination, is it'll be somewhere around exactly what you just said, around that mark, probably a little lower than 70, probably somewhere in the 60s. It all depends on how, when they look at how people are performing versus how people did on the 10-year exam to make it a relatively similar pass rate. And I will say this, that if you look at the pass rate of MOC, which is currently in the low 90s, there is no intention for that to get any worse. In fact, it's supposed to get better. So I would say that that's the expectation. So I think as they calculate those numbers, it'll probably be somewhere around above 50, but below 70 is my guess. But again, I'm not saying that based on any data that they've shown us yet. We've said to them at every meeting that they need to make this happen as soon as possible for exactly the reason that you articulated.